Hi, in this lecture we will learn about neonatal jaundice. Rise in serum bilirubin level of a neonate above normal is known as neonatal jaundice. Clinically, jaundice appears in a neonate when serum bilirubin is greater than 5 mg per deciliter as compared to adults in whom it becomes clinically visible when greater than 2 mg per deciliter. In an adult, the normal total bilirubin level is around 1.2 mg per deciliter. That means any clinically visible jaundice in an adult is always pathological. However, rise of the serum bilirubin in term infant up to 12 mg per deciliter is in the physiological range, and this value tends to be higher in preterm infants where it can rise up to 15 mg per deciliter. This means that some amount of jaundice is physiological in an infant. In fact, about 60% of term infants and 80% of preterm infants will develop jaundice. So let us understand the cause of this jaundice. 1. Shorter lifespan of RBC, and since bilirubin is the breakdown product of RBC, it rises. 2. Poor hepatic uptake of bilirubin. 3. Poor conjugation of bilirubin due to immature UDP glucuronal transferase enzyme. And 4. Increased enterohepatic circulation. So let us understand the difference between physiological and pathological jaundice. The characteristics of a physiological jaundice are: 1. It never appears within the first 24 hours. Any jaundice in the first 24 hours is always pathological. 2. It never exceeds 15 mg per deciliter. That is, it would never appear on the palms and soles of a neonate. If it does, it is pathological. 3. It is never present beyond 1 week in a term infant and beyond 2 weeks in a preterm infant. If it does, it is a characteristic of pathological jaundice. 4. Rate of rise never exceeds 5 mg per deciliter per day. And 5. Urine does not stain the diaper. That is, it is not conjugated bilirubin. In fact, high-colored urine and clay-colored stools are always pathological. So any infant with conjugated bilirubin levels more than 2 mg per deciliter is suffering from pathological jaundice. Now let's understand the causes of pathological jaundice. They are divided into unconjugated jaundice and conjugated jaundice. Unconjugated jaundice is further divided into jaundice due to increased production of bilirubin and jaundice due to decreased conjugation of bilirubin. Conjugated bilirubin is further divided into non-obstructive conjugated hyperbilirubinemia and obstructive conjugated hyperbilirubinemia. Causes of increased production include hemolysis, polycythemia, cephalhematoma, and delayed cord clamping. Causes of decreased conjugation include Crigler-Najjar syndrome, Gilbert syndrome, Down syndrome, hypothyroidism, and breast milk jaundice. The causes of non-obstructive conjugated hyperbilirubinemia include infections, which can either be viral, that is cytomegalovirus, rubella, or herpes infection, bacterial, that is tuberculosis or syphilis, parasitic, caused by toxoplasmosis, and toxins seen in sepsis, UTI, and total parenteral nutrition. Metabolic causes include cystic fibrosis, galactosemia, alpha-1 antitrypsin deficiency, tyrosinemia, and many others. Causes of obstructive conjugated hyperbilirubinemia include the intrahepatic causes are Caroli's disease, congenital hepatic fibrosis, Alagille syndrome, Dubin-Johnson syndrome, Rotor syndrome. Extrahepatic causes include extrahepatic biliary atresia, choledochal cyst, common bile duct strictures, and choledocholithiasis. Finally, let's understand the difference between breastfeeding jaundice and breast milk jaundice. Breastfeeding jaundice is due to decreased supply of breast milk. That is, the breast milk is insufficient. This will cause dehydration, which will lead to increase in the enterohepatic circulation and therefore jaundice. Breast milk jaundice, on the other hand, is due to certain factors which are present in the breast milk, that is pregnanediol and free fatty acids, which hinder the conjugation of bilirubin and therefore lead to hyperbilirubinemia. So, breast milk jaundice is caused due to increased intake of breast milk. Another point of difference is that breastfeeding jaundice usually appears in the first week of life. In contrast to this, breast milk jaundice is usually seen between second to third week of life. An easy way to remember this is that breastfeeding jaundice is caused due to a defect in the feeding, that is, reduced breast milk, whereas breast milk jaundice is caused due to a defect in the milk, that is, the ingestion of milk is causing the jaundice. Coming to the clinical features of neonatal jaundice. First and foremost is yellowish discoloration of sclera and skin. This yellowish discoloration shows cephalocaudal progression. This cephalocaudal progression is known as Cramer's rule. According to Cramer's rule, icterus which is present in the head and neck region corresponds to a serum bilirubin level of 4 to 6 mg per deciliter. If the upper trunk is involved, that is above the umbilicus, the values correspond to 6 to 8 mg per deciliter. If the lower trunk and the thighs are involved, the values correspond to 8 to 12 mg per deciliter. Involvement of the arms and the legs correspond to values of 12 to 14 mg per deciliter. And if the palms and the soles are involved, the value is greater than 15 mg per deciliter. And let me remind you, involvement of palms and soles, that is value greater than 15 mg per deciliter, is always pathological. Now coming to the neurological features of neonatal jaundice. Neonatal jaundice can cause bilirubin encephalopathy. In its mildest form, it can cause sensory neural hearing loss. However, it can also cause kernicterus. Now, kernicterus occurs due to deposition of indirect, that is unconjugated bilirubin in basal ganglia. Features of acute bilirubin encephalopathy include lethargy, poor feeding, loss of Morrow's reflex, decreased deep tendon reflexes, respiratory distress, opisthotonus, bulging fontanelle and shrill high-pitched cry, and ultimately it can lead to convulsions, coma and death. In its chronic state, it can lead to cerebral palsy, that is the athetoid variety. And that is why it becomes important to identify and manage pathological jaundice appropriately. Coming to the diagnosis. For patients with significant or symptomatic hyperbilirubinemia, the following tests need to be performed. First test is the direct and indirect fractions. Second, blood grouping and Coombs test. Third, hemoglobin with reticulocyte count. And fourth, peripheral smear. So first, let us discuss indirect hyperbilirubinemia. Once we find out that the patient is suffering from indirect hyperbilirubinemia, we perform Coombs test. If Coombs test comes out to be positive, then the cause is either Rh incompatibility or ABO incompatibility. However, if the Coombs test is negative, we then look at the hemoglobin levels. Hemoglobin levels, when increased, indicates polycythemia, which could be due to twin-to-twin transfusion syndrome, small for gestational age babies, and delayed cord clamping. If HB is normal or reduced, we then perform reticulocyte count. Now the reticulocyte count can be normal, indicating enclosed hemorrhage, increased enterohepatic circulation, bowel obstruction, or neonatal asphyxia. If the reticulocyte count is increased, we then look at the peripheral smear and look at the RBC morphology. If it is characteristic, it could indicate spherocytosis, stomatocytosis, elliptocytosis, etc. Non-specific RBC morphology indicates G6PD deficiency, any other enzyme deficiency, or DIC. If the RBC morphology is normal, again, it could indicate enclosed hemorrhage, increased enterohepatic circulation, bowel obstruction, and neonatal asphyxia. Coming to the management of indirect hyperbilirubinemia. Now, the goal here is to prevent neurotoxicity. So, our treatment options include 1. Phototherapy, 2. Exchange transfusion, and 3. Drugs. Coming to phototherapy, the wavelength of light should vary between 425 to 475 nanometers. The mechanism of action of phototherapy is 1. Structural isomerization. This is the main mechanism of action and it is irreversible. It causes the conversion of bilirubin to lumirubin, which is then excreted. 2. Photoisomerization. This process is reversible. And photooxidation. Photoisomerization and photooxidation are minor mechanisms of action. LED light is preferred over fluorescent lights. Now, the precautions needed to be taken during phototherapy is to cover the eyes and the genitalia of the baby, as otherwise it could lead to toxicity, and to monitor the body temperature. Coming to the complications of phototherapy, it can lead to loose stools, further causing dehydration, hypocalcemia, temperature disturbances, that is either hypo or hyperthermia, retinal and gonadal toxicity. If phototherapy is given in conjugated hyperbilirubinemia, it can further cause bronze baby syndrome. Contraindications of phototherapy include porphyria. Now, exchange transfusion. Indications of exchange transfusion include very high bilirubin levels running the risk of kernicterus and phototherapy failure. Indications of exchange transfusion in infants with Rh isoimmunization include cord hemoglobin less than 10 grams per deciliter, cord blood PCV less than 30, and cord blood bilirubin greater than 5 mg per deciliter. The complications of exchange transfusion include metabolic acidosis, electrolyte imbalance, hypoglycemia, hypocalcemia, thrombocytopenia, volume overload, infections, and arrhythmias. The drugs used for indirect hyperbilirubinemia includes IVIG. This decreases the need for exchange transfusion by decreasing hemolysis and is given in isoimmune hemolytic disease. So finally, let's understand the cutoff values of bilirubin for giving phototherapy and exchange transfusion. First, let's look at a term infant. If the age of the baby is between 24 to 48 hours and serum bilirubin level is greater than 15 mg per deciliter, we give phototherapy, and greater than 20, we give exchange transfusion. Between 48 to 72 hours, the cutoff value for phototherapy is 18 mg per deciliter, and that for exchange transfusion is 25 mg per deciliter. Greater than 72 hours, the cutoff value for phototherapy is 20 mg per deciliter, and that of exchange transfusion is 25 mg per deciliter. Now, coming to a preterm infant, phototherapy is given if the serum bilirubin level is 1% of the birth weight in grams. For example, if the birth weight of the baby is 1000 grams, then 10 mg per deciliter will serve as the cutoff for phototherapy. Exchange transfusion in a preterm infant is given at serum bilirubin level 1% of the birth weight plus 5 mg per deciliter. Now let's understand the evaluation and management of conjugated hyperbilirubinemia. In addition to the tests already performed, we need to perform other tests such as AST, ALT, GGT, hepatic ultrasonography, hepatitis B, hepatitis C screening, HIDA scan, cholangiogram, alpha-1 antitrypsin deficiency studies. Coming to the management, since conjugated hyperbilirubinemia is not toxic, we need to search and treat the cause for the resolution. Again, phototherapy in conjugated hyperbilirubinemia will cause bronzing and lead to bronze baby. So we've discussed about neonatal jaundice, the characteristics of physiological jaundice, the causes of jaundice, the clinical features, diagnosis and management of indirect and direct hyperbilirubinemia. I hope you enjoyed the lecture. If you did, please like, comment and share and subscribe for more such videos. Thank you.